want to talk about that for a second. So you all have probably heard of MAOI inhibitors, right? MAOI inhibitor drugs are typically prescribed for mood disorders. And so you hear that term a lot, MAOIs. What exactly does that mean? So there's an enzyme called monoamine oxidase that is involved in actually removing the neurotransmitters, norepinephrine, serotonin, and dopamine from the brain. This is not a good thing, right? And so some young people, as well as some adults, but young people may have this enzyme that basically eats away at these quote feel good mood boosting chemicals, right? Serotonin, dopamine, epinephrine are all kind of mood boosting chemicals that our bodies naturally produce, right? When somebody does not have this enzyme, their mood is probably going to be pretty stable, right? And even when they experience a low point in life, they're going to be able to kind of resume and go back up to their kind of normal level of functioning pretty quickly. But with young people that are really vulnerable to mood disorders and that do have this enzyme, what happens is this enzyme starts to eat away at the levels of the dopamine, the serotonin, and the norepinephrine. And so we see that there could be this biological brain-based vulnerability. And that is where the MAOI inhibitors come in, because those MAOIs, what they do is they stop that enzyme. They reduce that enzyme from eating away at the serotonin and dopamine to try to keep those chemicals up at appropriate levels. That is why our continuity of care is so very important, and having very good relationships with psychiatric providers and med providers in your community where you are serving youth is so very important. I know that is of real importance for me, is to know psychiatrists and to know these treatment centers and physicians and psychiatrists that we know we can refer our young people to, because as mental health professionals, we have limitations on exploring some of these biological, neurologically based vulnerabilities. And so we really need to do our best to connect to providers and have confidence in saying, yes, please go see Dr. Reynolds. I've had many other young people go see them, and they are wonderful at helping a young person and their family figure out what's going on from a brain perspective. Is there a genetic biological test for monoamine genes? I'm going to say no, but that doesn't mean that they can't run other blood tests that may capture some of that information, but I don't know if we have a specific test for that. You need a psychiatrist who knows the science as well as the art to diagnose a person needing those MAOIs, right? They're not as common as they used to be used. Now we're relying more on those SSRIs, are going to be the most common ones. But MAOIs can still be prescribed, especially for young people. We may still sometimes see some of those being prescribed, but you're going to find a lot of providers going to be going to some of those SSRIs. Can pharmacogenetics tests be helpful regarding Kathleen's question? I would say so, Stephen. I would say if that is a possibility, and if a client and their family has access to that, and there is a medical provider that can help coordinate that, I think that that would be good to explore, because I think that may give us some guess or some idea into some of that information. My prediction is probably within about 10 to 15 years, we will have these tests. We will have a blood test that will be able to reveal not only levels of, is this enzyme present, but also revealing other things that may give us this specific genetic information. So every day we're doing more and more genomic typing. And I just read an article about a month ago that was on genetic typing regarding depression and bipolar disorder. And they have a preliminary study that shows that with a series of blood tests, they are now actually able to type this blood, and it gives them information going back 3 generations to see that likely the relatives of this individual likely also had similar blood results. So that's really interesting. We're kind of on the cusp and the precursor of being able to get this information from a patient's blood. Yes, I agree with that, Vanessa. Many of your patients don't want to take any SSRIs because they can't see it. Yes. So this biological area is of real significant importance for all mental health disorders, but we know for mood disorders, we can't just conceptualize mood disorders as being environmental or being social or being, from parental influences. We really have to understand that there can be some of these biological risk factors. So as you're doing your assessments, even though you're not a biologist and even though you're not a physician, you can still gather as much reasonable information as you can to begin to get an idea of what biological vulnerabilities may exist. So next we're going to look at psychological risk factors for mood disorders. But before we look at that slide, let me ask you all, what do you think would be some psychological risk factors for mood disorders? Abuse, attachment injuries, you got it. Trauma, Colleen, the ACEs, great way to kind of get all this information. Yes, conflict, death, separation, Vanessa, substance use during pregnancy, Jennifer, which would really kind of be probably this biological. There could be a lot of biological influence there, right? To that unborn baby and the brain development and the residual settling of some of those drug chemicals within that unborn baby. Absolutely. Yes. And a lot of you, of course, trauma, I think, is like one of the most common psychological connections we see with mood disorders. Now, we know that there are young people that have not experienced trauma that can still have mood disorders, but probably we could imagine that more than half of youth with mood disorders, there's probably some aspect of trauma in their history. Yes. Here's some other ones that maybe are not as easily thought about when we look at psychological risk factors. Think about, for example, body dissatisfaction and early dieting. So I remember like growing up in the 70s and 80s, and not that there wasn't like a diet culture back then. Like there was, diet soda and there was, smoke these light cigarettes so you can stay slim. And there was still some of that messaging. But what was one of the main differences between the 70s and 80s and the diet messaging and diet culture now? There's like a significant thing that's different. Number one, it's increased, but what has really perpetuated, especially for young people, this body perhaps dysmorphia and really the right social media, the influence, especially on young people and the sponges that are their brains, right? And the way in which they imagine that I should look like that. And so that can be one of those psychological antecedents to a mood disorder. Sweetened beverage consumption. Uh, we are finding more and more out about the origins of cancers, and we're seeing more and more cancers diagnosed in younger people. And I think we really need to begin to acknowledge how some of the sweeteners and some of the processed food and artificial this and that, and the ingredients you can't pronounce, that is also perhaps contributing. Dysfunctional emotional regulation, of course, would be a psychological risk factor. Internet gaming disorder or video game addiction. Certainly, we would see this, especially in youth boys. Not that youth girls cannot experience this, but especially in our young boys, we see that this can be really problematic. Less attachment to parents and peers or problems with peers. This is that thwarted belonging where a young person doesn't have a place within their family, perhaps within a peer group, even having just one or two friends. They don't have one or two friends. Worried about school grades. So there's this perseveration. This may come from perfectionism. It may come whether that perfectionism is self-imposed or imposed, by others. But this is that over worry, that anxiety can then transition into a mood disorder. Low self esteem and lack of self kindness and self compassion. negative thinking and recall styles. So that would be that cognitive brain, other mental health and behavioral problems, so co-occurring disorders. We also see, especially with cannabis and tobacco use in youth, very vulnerable to mood disorders. And, we know that there's still controversy around marijuana legalization and the use of marijuana. We know that within adults, there are less documented problematic factors compared to in youth. In youth, we have documented research that shows that introduction to cannabis at a young age can really exacerbate mood disorders. And so that is something that if you have a youth, disclosing, they're engaging. We're not going to go into uh, the DARE program lecture, but we need to be aware of that and aware of how that may be impacting that young person's mood. And then again, social media, problematic use of social media, unhealthy, extensive, relying on social media for validation, for direction, for life goals, for acceptance. And so we really see that whereas adults, we can usually get on social media and you see something, somebody says something crass, and you're like, whatever, and you go on about your day. But for a young person, they're not as easily developmentally going to be able to just say whatever and go back to whatever they were doing. They're going to get really caught up in that situation, in whatever that environment is. There's that vulnerability for our young people with cannabis use of that increased risk for psychosis, which interestingly, we don't see nearly as much in adults. But for some reason, cannabis in a young brain, it just does not mix, especially chronic cannabis use. We really see that there's a lot of vulnerability there.